Lung nodule biopsy in a patient with UIP-IPF. I am Dr. Bhavin Jankaria, and this 73-year-old with IPF came with progression of disease and a new left basal lung nodule. A biopsy was needed. This was the best route available. And this case I posted based on this article that was published a couple of months ago, where eventually when they biopsied patients with UIP, they found that the main factor that affects the occurrence of pneumothorax is whether the biopsy is done through normal lung or lung involved by fibrosis. So in our patient, I used a 20 gauge Cook with a 10 millimeter throw. I had to go through abnormal lung. I deployed the gun here, took 6 scores for histopath, 2 for microbiology, rapid rollover, didn't show a pneumothorax, and a follow-up at 6 minutes was also fine. The final diagnosis was granulomatous disease. And here are some other examples. Another patient with IPF went through involved lung. There was a 10 cc stable pneumothorax. And these two patients, the lesion reaches the pleura, so there was no involved lung in between, and in both of them there was no pneumothorax as expected. Biopsies of focal lesions in patients with ILDs are required because of the increased risk of malignancy and infections. They should be done with the understanding, which is quite intuitive, that a path through uninvolved lung will involve fewer complications than a path through involved lung. That's the QR code to the longer video, more examples and a more detailed explanation of the case. And that's the link tree to all of my posts on other sites as well.